Okay, so then, cardiac disturbances can be caused from a couple different reasons. The primary one we come across is cardiac disease, specifically coronary artery disease. Although you can have congenital heart disease, and you can have a situation where you have fluid overload and congestive heart failure without having an actual damage to the myocardium. Majority of the time, it's the coronary artery disease that is culprit. You can also have disturbances secondary to a traumatic event, a deceleration injury, where the heart becomes bruised, if you will. Some drug-induced cardiac disturbance and electrolyte obviously can cause some kind of problems. Just as a quick review, we know that the heart is located inside the mediastinum. The left ventricle is basically at about the fifth intercostal space, mid-clavicular line. We know the point of maximal impulse is the point at which we can hear the heart the strongest. And when there's a shift, that tells us that the heart is actually moving. It's an inverted triangle, so the base is at the top, right around the second intercostal space, and the apex is at the bottom. The heart is also rotated inside the chest, so the anterior surface is really looking at the right ventricle, and the inferior surface is where the two ventricles meet. So there's the little heart lying there. You can see the size of it, about 300 grams roughly. It's going to vary based upon the individual that we're talking about, their degree of heart disease. Notice all the fatty tissue that accumulates on the surface of the heart. Nasty. 4 chambers, 2 upper ones known as the atria, that receive blood from the back from the lungs from the pulmonary veins, or on the right side from the inferior and superior vena cava. There's this indentation called the coronary sulcus that encircles the heart and demarcates where the atrial ventricle junction is. And there is a intra-atrial septum made of connective tissue. Most of the blood just goes ahead and flows right on through the atria when the valves are open, the bicuspid and tricuspid. There is also some portion of blood that is pumped physically by the atria, and when we get to some of these atrial dysrhythmias, we lose that increase in blood flow, that extra 30%. Lower 2 chambers, the ventricles, are the actual pumping of the blood. There is a septum there also, and there's also an interventricular sulcus that runs perpendicular to the coronary sulcus and demarcates the right and left ventricle. Left ventricle is far thicker than the right because it has to pump in a higher pressure system. And the volume of the ventricles are about 150 milliliters, of which 70 to 80 milliliters are pumped with each beat, as being a stroke volume. You can look at the heart surface and show where the septa are, and inside those septum are where the coronary arteries lie. 3 layers: endo, myo, and epicardium. Epi being the outermost, it's analogous to the visceral layer of the serous pericardium. The myocardium is the big one that we're concerning ourselves with because that's the muscular level. And this is where it contains both the cardiac muscle fibers and the conduction system. And this is just looking at a cross cut. You can see the myocardium by far is the thickest of the 3. And then lastly, the pericardium is basically the sac that's on the outside, that the protective mechanism from trauma and also from infection. It's made up of 2 layers, the fibrous and the serous portion. You can see the fibrous pericardium there, and the serous pericardium on the inside. There's some space between the layers that holds a small amount of fluid, and it's this accumulation of additional fluid in that spot that would cause things like pericardial tamponade, that you would need to perform a pericardiocentesis or pericardial window to drain it back out again. Cardiac muscle is similar to skeletal muscle in how it functions. These muscle cells are enclosed in the what's called the sarcolemma, and these contractile elements of myocardial muscles are myofibrils, and protein is there for the contraction. The two protein filaments are actin and myosin, and enzymes that are released when there's damage to the myocardium, troponin and tropomyosin. Troponin is what we're going to find one of the important markers for a myocardial infarction. There's just a graph out of your, or a graphic out of your text that shows this thing called the sarcolemma and how those actin and myosin function to cause that muscle to contract. Very simplistic mechanism. This is what I was talking about. As the myocardial infarction happens, you have a release of these what we're going to call biomarkers into the bloodstream, in the level that they are there for indicates the degree to which the myocardial tissue has died. Creatinine kinase, and there is actually a sub portion of creatinine kinase, what's called a myocardial band, that is specific to cardiac muscle. Creatinine kinase will rise when any muscle is damaged. So if you are a runner and you tear something in your bicep or your leg, let's say, CK would go up. If you have specific myocardial damage, CKMB will go up, in addition to the creatinine kinase. Myoglobin is another substance that is released, and there are a couple different troponins. Troponin, that should be. That's the correct spelling. I'm sorry, I misspelled that one there. That would be elevated, and there's actually some other ones that they're finding now. Heart-type fatty acid binding protein. That we're constantly trying to find additional biomarkers that will indicate that there's a presence of damage to the myocardial tissue. We know there's some valves that are within the heart to separate the atria from the ventricle. Tricuspid on the right, bicuspid on the left. They're basically these flaps that are held in place by the chordae tendineae when papillary muscles contract. They close during systole to prevent backflow back into the atria. And they allow for pressurization of the ventricle without having the pressure transmitted back into the atria. When there's damage to them is when we end up having things like regurgitation, where we have backflow. It's going to have a sound of a murmur, and the valve itself can also be stenotic, meaning it's stiff and not able to open and close properly. The two semilunar valves, pulmonic and aortic, they look like the moon, blah, blah, blah. These do not have any papillary muscles, or chordae tendineae, and they close during diastole and prevent backflow into the ventricle. And they're really just closing because of a pressure difference that is present. Same thing can happen if they happen to be defective, that you can end up having backflow, generating murmurs, and the aortic valve can be stenotic in the process. And these various heart sounds occur because of the blood flow is moving. Just go to the site, see what's there. Forgot to check that link to make sure it was working this morning. Come on. There we go. an extra heart sound there. Okay. Unlike pulmonary medicine, cardiac medicine has correlated sounds quite well to actual physiological changes. I don't think we have done as great a job as that. You should know the S1 and S2, the lub and the dub. As far as closure of the AV valves is what the S1 sound is. Closure of the semilunar valves is what the S2 is. And then S3 and S4 are normal in children but become pathologic in adults. And they're basically murmurs. There are movement of blood. And the primary reason is either the valve is incompetent and you have backflow, or if you have normal flow but it's through a stenotic valve, that's going to cause a murmur also. During systole, when the blood is being ejected from the ventricle, if my atrioventricular is incompetent, you're going to have backflow back into the atria. That's going to cause a systolic murmur. Could also be because of a stenotic semilunar valve. The aortic valve, for instance, will cause a systolic murmur also. So you need to distinguish between the two when you're hearing it and what could possibly be the cause. Remember back from Mary's class about where to auscultate? You got to think of that heart not being, I mean, it's kind of weird to be listening for the aortic sound on the right side of the patient's chest when the aorta should be on the left side, but that's because the heart is rotated. Okay. So the tricuspid valve is just to the right of the sternum, and even further right is where the mitral is heard, and then your pulmonary aortic valve, pulmonary valve, and your aortic valve are reversed. So this is just showing the cardiac cycle, which valves are open. That should be nothing that you haven't heard previously. All right, coronary arteries are right off the aorta as at its root, just beyond the aortic valve. The oxygen consumption of the myocardium is exceedingly high. You can see 65 to 75% of oxygen is extracted, so your venous blood coming back is profoundly lower in saturation. And the only way we can get more oxygen there is to have improved coronary blood flow. We know the muscle itself cannot fill during contraction, it only fills during diastole. So this leads to problems with rapid heart rates, not allowing for adequate coronary artery filling. The veins dump into the coronary sinus, except for the Thebesian, and we know that's one of the sources of our shunted blood anatomically. Nothing here should be all that unknown. You can see with the intraventricular sulcus there, and the coronary sulcus going around. I do want you to know this chart, put a little star by it. This is a very important one. First of all, it talks about the right coronary artery. It actually has two components. You don't need to know the two components so much as you do need to know what it does. So this middle column, the right coronary artery feeds the right side of the heart, both the right atrium and the right ventricle. It also continues down and feeds the inferior wall of the left ventricle, the posterior wall of the left ventricle, and some of the intraventricular septum. Okay, so those are right coronary arteries. In addition, we not only have muscle mass, we have a conduction system. Most of the blood flow to the sinus node comes from the right coronary artery, And virtually all the blood flow to the AV node comes from the right coronary artery. Okay. And it also continues on with some portions of the bundle of His and some of the fascicles of the left bundle branch. So damage to the right coronary artery would yield itself with a potential right ventricular, also a inferior wall MI, a posterior wall MI, and conduction defects. So your high degree blocks are secondary to a right coronary artery being damaged, typically. Okay. On the left side, there's two primary branches that you do need to know. The left anterior descending and the left circumflex. The anterior descending is the one that is most critical, because that's going to feed the left ventricle as well as part of the septum. It also feeds the right bundle branch and a good portion of the left bundle branch. And this is the one that, when it gets damaged or it gets occluded, causes massive loss of blood pressure, cardiogenic shock. Is secondary to a left anterior descending being occluded, because the anterior wall is where the ventricle generates all of its power from. And finally, the left circumflex wraps around the left side of the heart. It feeds the left atrium and to some degree the SA node, and it also feeds the lateral wall of the left ventricle and continues around to the posterior portion of the left ventricle. So there's multiple places where blood flow can come from in most cases. Are we good on that? Is that vaguely a review? Because what will eventually happen is we will get a 12-lead EKG. We'll identify that there is a specific portion of the heart that is ischemic or infarcted. I can then say, okay, which artery do you suspect will be the culprit in this? Okay. And what kind of conduction defects might you anticipate happening? All right, aortic arch, you should be aware of that the right brachiocephalic subdivides into the subclavian and the right common carotid. On the left side, they're individual vessels. And this is kind of what they look like. There's your brachiocephalic, branching the right common, right subclavian, left common carotid, left subclavian. We know that the control of the vascular system is done through baroreceptors, both the carotid and the aortic. They're adjacent to the chemo but separate from the peripheral chemoreceptors, who respond to changes in partial pressure of oxygen, carbon dioxide, as well as pH. And they'll also generate a sympathetic and a parasympathetic discharge, as you're probably well remember back from pharmacology when we talked about that. People use the term arrhythmia, and it really is not the best term. Dysrhythmia is what we're talking about. Arrhythmia means you're asystolic, you have nothing. Dysrhythmia means that it's a disturbance. So, is it semantics? To some extent it is, but it's something that you probably should use the correct term. The electrocardiogram, the EKG cardiogram, it's German, so the C in cardiogram would be actually a K. It measures the electrical current of the heart. We know that there gives 12 different pictures of the heart. Well, the 12-lead EKG has nothing to do with the pumping facility, only has to do with the electrical current going through. You can have a normal sinus rhythm and be dead. We'll find what we're going to call that pulseless electrical activity, where the EKG doesn't correlate with the cardiac output. Remember back normal sinus, there's a stepwise fashion you should always go through when you're evaluating rhythm strips, and that is part of this program, is that you'll not only identify dysrhythmias, you'll also look at the 12-lead picture and look at as far as what's happening there also. Normal sinus has that rate somewhere between 60 and 100 beats per minute, where the origin is the sinus wave. The sinus node, giving us a normal, upright, uniform-looking P wave. The PR interval somewhere between 0.12 and 0.2, should know that. QRS complex is less than 0.1, should know that. Okay, and that's just a normal sinus. We know that cardiac cells are made up of two types, specialized either for conduction of impulses, and this is what we're going to call the pacemaker cells that have automaticity, can fire on their own. And then the myocardial cells, or the working cells, are the ones that actually generate the force to pump blood out. Under normal conditions, those myocardial cells don't generate an impulse. They need instead an external stimulus to start it. So the sinus node has to fire in order for the rest to work. The reason why this happens, why this electrical current happens, is a shift in intracellular and extracellular ion gradients. And the electrical impulses are due to that change of the ions back and forth across. And we measure this as a waveform. 3 electrolytes you need to be aware of: sodium, potassium, and calcium. And they move through specific channels. And some channels are only permeable to calcium, some are only permeable to sodium. And then the movement is what causes this depolarization or repolarization to end up happening. I do want you to know that the rapid influx of sodium is through a fast channel, where sodium and calcium also have a much slower movement through what are called slow channels. So there's 2 different ones that are ending up being there. This is how it's classically described, from a resting membrane potential through depolarization, a slight overshoot, a plateau, and a repolarization. And all this is moving is during depolarization, the movement of potassium out and the movement of sodium and calcium in. We think of the intracellular concentrations being slightly negative compared to the extracellular. If you add up all the cations on the outside and compare it with the cation on the inside, there's more positive charge outside than inside. Yes, I know potassium is a positively charged cation, but there's less of that positivity inside at rest than there is outside. Once depolarization happens, that's that sudden spike upwards. That's the movement of sodium through the fast channels, as well as calcium, and to some extent sodium through the slow channels, to have that change in polarity. So it's now predominantly positive on the inside compared to the outside. Just another shot of it. You can see the massive movement of sodium in and the slow movement of calcium out. Causes that to happen until we reach that plateau, after which time we repolarize by having everything move in the opposite direction. And this is just another picture of it, showing that influx of sodium and calcium. And they show how it's timed to the EKG pattern. Okay. And this is just the repolarization phase, where we come back to our normal one. There are 2 refractory periods. There's an absolute refractory period that starts from the beginning of the QRS to about the middle of the T wave. That absolute means that the myocardial contractility cannot respond to further stimulation. So there's no possible way to begin another impulse until that absolute refractory period is over. Relative refractory is from the middle of the T wave to the end of the T wave, and this is where the heart is really vulnerable. Any stimulation at that point is chaotic. It throws the patient from whatever rhythm they're in into VFib. So it's what has been called the R on T phenomenon, where a stimulus placed at the middle to end of the T wave is lethal. Okay. This is showing the initiation of a beat because of the influx of sodium. There's multiple antidysrhythmics. I don't expect you to know what they each do. For our purposes right now, we'll just I show you this and we all nod our heads and okay. But I'm never going to ask you what a class 3 antidysrhythmic does compared to a class 1. It's a nice little drawing of the pathway that the impulse that originates in the sinus node goes. You can see the multiple pathways that are taken to get from the sinus node to the AV node, and the movement of that impulse to the opposite atria also. Then from the AV node through the bundle, and I really just consider them one functional thing, the AV junction, down through the left and right bundle branch. The left has much more fascicles or much more sub-branches that are there than on the right, and they ultimately end in the Purkinje fibers. That's old news, right? We're all good on that. Sinus node primary pacemaker, 60 to 100, receives its blood primarily from the right coronary artery, slightly some from the left coronary, from the left circumflex. It has both sympathetic and parasympathetic innervation, and discharge of the sinus node propagates a wave, like I just said, through Bachmann's bundles, here, these dotted lines, to the AV node, and that happens very, very quickly. It's not a very long duration that you end up having. Once it gets to the AV node, that's located basically in the middle, where the right atrium, right ventricle, and left ventricle all kind of come together in that middle portion. Opening near the coronary sinus. Usually, again, supplied by the right coronary artery, but does have some degree of being fed by the left circumflex. And if there's a delay, it functions to delay the conduction to allow the atria to contract and fill. And if I have an atrial rate that is way too rapid, the heart will attempt to slow it down by prolonging the time that the impulse is held in the AV node. Then the other portion of the AV node is a bundle of His, and again, it just again allows for a delay to happen to allow the atria to fill. This is where also the impulse would originate if the sinus node were to not function. The AV bundle has the ability to function at a rate of 40 to 60. And then it goes down the right and left bundles. The right obviously innervates the right ventricle, the left innervates the left ventricle. The left has 3 different fascicles, as I mentioned, are the anterior, posterior, and septal, that feed those portions of the muscle. And then lastly, the Purkinje fibers are the smallest of the branches, and they go right down to the myocardium as well as the papillary muscles, and they have an inherent rate of something less than 40. Okay. So another good one you might want to put a star by, because it kind of tells you the various components of this conduction system, where they're located, and what they do. Fair? No, it's not really fair. So 60 to 100, 40 to 60, and then less than 40 for the Purkinje fibers. A true ventricular origin, if you will. A couple different reasons why you might have some dysrhythmias present. First of all, enhanced automaticity. So for whatever reason, the junction, the AV junction says, hey, I want to fire before the sinus node does. It has enhanced automaticity. It can function as a primary pacemaker. It's not supposed to, but there are such situations like junctional tachycardia, where the origin of the beat is in the junction, and it's firing before the sinus node does. Might be because of sinus node damage. It could be because just an irritable AV junction. Enhanced automaticity. Reentry is one of the causes and one of the things that we'll see often with supraventricular tachycardias. And this is where an impulse coming down innervates the muscle fiber, but also has a little mechanism whereby there's a one-way door, and it can't come down this way down this branch, but it can circle itself around and re-stimulate that point again. So an irritable atrial focus can come down, innervate through the normal pathway, but also come back around and innervate itself again. That's what leads to those kind of tachycardias that you end up seeing with SVTs. It's called a circus motion, or escape beats are a dysrhythmia where the primary pacemaker isn't functioning, so something else takes over. You can have a junctional escape beat. You can have a atrial escape beat, a PAC. You can end up having a ventricular, a PVC, occurring, or an idioventricular escape beat. And then lastly, the cause of dysrhythmia are the blocks, and those are always fun. Sure they are, Rick, whatever you say. But those are all different ways that dysrhythmias can occur. So when we look at the EKG, we're looking at the electrical activity. We're going to look at the rate. We're going to find out to what extent any injury or disease is present. Who's the pacemaker? Who's in charge? Who's starting this off? And then when we do treatment, we want to see how the response happens. And for each of the dysrhythmias, we'll go through what the proper treatment should be for it so that we can manage it appropriately. I don't think I've seen a metal disc or a metal suction cup in like forever, but that's the way we used to do them, with little suction cups placed on the body. Now they're typically just disposable tabs, and it is critical for the proper placement. Now notice I'm using the term electrode and lead differently. An electrode is something that I place onto the person's chest or body. A lead is a combination of two of those electrodes. And it's looking for the activity that occurs between those two. One electrode is always designated as a positive. One electrode is always designated as a negative pole. The view of the lead is always looking from the negative to the positive. As the current is moving in the direction of a lead that looks in that direction, well, that just made no sense, it's going to have a positive deflection. So for instance, within the heart, the atria moves, or the atrial contraction moves from the SA node down to the AV node in that downward direction. Any lead that looks in that direction has a negative pole on the left shoulder and a positive pole on the right left foot, lead 2 in other words, will have a positive shaped P wave. Does that make sense? Okay. The impulse is also moving ever so slightly from the left upper corner of the atrium to the right lower corner of the atrium, so there's a movement from left to right. So any lead that looks in the leftward direction, say lead 1, will have a positive deflection also. Not as big as lead 2, but there will be a positive deflection there. If the movement is away from that, it's going to have a negative deflection. This is very important, and it becomes the reason why we see Q wave development during a myocardial infarction. The impulse can't continue in the direction it was going, so it has to turn around. And in the process of turning around, it develops a negative waveform. Am I okay on that? That's a very, very important part of this. We know that there are what are called standard limb leads. And these are looking at the frontal or vertical plane. Lead 1, lead 2, lead 3. Lead 1 is from the right shoulder to being negative, the left shoulder being positive. Lead 2 is right shoulder negative, left foot, if you will, positive. And lead 3 is left shoulder negative, left foot positive. And you can see the different heights of the P waves as you're going across. These three together are what we call Einthoven's triangle, and it gives us a view of the frontal portion of the body. And there you can end up seeing the three tracings. Now there is something called chest leads, modified chest leads. And this is what we typically use in the cardiac care unit. And the typical ones we would use mostly is MCL1 and MCL6. Modified chest leads, they're basically mimicking what happens when you have V1 or V6, and they're using them on a continuous basis. And why we use them primarily is to distinguish if a bundle branch block is right or left, or if a PVC is originating from the right side of the heart or the left side. Our three unipolar leads that only have one positive end, the negative end is assumed to be that center of that triangle. These are your augmented voltage leads, one going to the left shoulder, one going to the right shoulder, one going to the foot, which is kind of even though we don't technically have a lead placed in the center of that, it uses the two leg limb leads to arbitrarily identify this bottom portion of that triangle. And then V1 through V6, you should be aware, if I asked you a question, where would you place this one, you should be able to tell me where it's placed. And there's a nice drawing of it. Have you guys had a chance to do an EKG in clinical 12 lead? Some places are really big on them, some places you'll never see them. Depending upon the RT department, especially on off shifts, a lot of times that's part of our job. So you're really good at it. So the lead 1, lead 2, lead 3, and your augmented voltage leads are all in the frontal plane. The chest leads, V1 through V6, are in the horizontal plane. Put them all together, we get our 12 lead. Yahoo! Now, if I suspect a right ventricular infarction, you might be asked to do a right-sided chest lead, which are exactly the same. We just reverse it. We call this one here V1R, this one here V2R, V3R, V4R, V5R, V6, V6R. And you actually need to physically relabel the ECG as a right-sided ECG. Not only can we do that, we can look at posterior using V7, 8, 9 on the left or on the right, be able to give us an idea of what's looking on the back side. And each of the leads look at a different part of the heart. If you think of where the positive electrode is, that's where the eye is looking in a certain direction. And we're going to put that all together to identify where the heart damage is. Everything that looks down, 2, 3, AVF, is going to tell us about the inferior portion of the heart. Lead 1 looks to the left shoulder. AVL looks to the left shoulder. V5 and V6 are looking at the left. So they're all looking at the lateral wall on that side. V1, V2 are septum. V3, V4 are anterior. And then you need to look at what we're going to call reciprocal changes, which are mirror images. Instead of seeing ST elevation, I see ST depression in opposite sides. Because the posterior wall, unless we're doing a posterior EKG, we're never going to pick up on it. Because you can't see that wall in the standard 12 lead. You have to do some extra stuff. And there's Eindhoven. Now that's one way to do an EKG. Put your leg and arms in a bucket and measure the electrical current. Kind of a weird way. If the leads are misplaced, if you have the leads backwards, this is what you'll end up seeing. First thing to look at is lead 2. Lead 2 should always have a positive P. If the P is negative in lead 2, you got the leads mismatched somewhere along the line. Second thing is that you have overall negative tracings in lead 1. And the third thing is that in AVR, which everything should be inverted, you have an upright QRS complex. And that's telling me that I got something backwards. Those are limb leads that you put in an incorrect position. So here we have, and this is displayed badly, but lead 2, lead 3, lead 1. Notice there's problems with 2 of the tracings and 1 of them is not. Which electrode should you check? Right shoulder, right foot, left foot. It is the right shoulder. How'd you get there? That's right. That's right. Lead 3 does not involve the right shoulder. The other 2 do. So we need to check that. Here's some examples. Again, we talked about a negative deflection in lead 2, AVR being upright. Those are all signs that your limb leads have been screwed up somewhere along the line. In this case, the left and right arm electrodes have been swapped. And I think we'll stop there. Because I think I get the sensation that my brain is hurting.